Right. Good day. Welcome to everybody who's joining in on this Hopkins at Home session. My name is Rajat Mittal. I'm a professor of mechanical engineering with a secondary appointment at the School of Medicine. And I'm looking forward to telling you all a little bit about COVID-19 transmission. This is obviously a topic that's of interest, remains of interest to everybody. And hopefully what I'll offer today is kind of my perspective as an engineer, looking at the various aspects of COVID-19 transmission. And throughout my talk, I'll be using this idea of kind of different states of knowledge. Known knowns are facts. On the other hand, unknown unknowns kind of correspond to profound ignorance about any topic. And it turns out that COVID-19 transmission, what we know and what we don't know, kind of falls through this entire spectrum of everything from things that we fully understand to things that we really kind of are still struggling to figure out. So with that kind of an introduction, let me dive right into it. So first of all, just to set the stage, hopefully everybody kind of at this point, after about 2 years of dealing with COVID-19, we all understand that COVID-19 is a respiratory infection, and it's primarily transmitted by the respiratory droplets that are coming out of the mouth and nose of an infected person. Just to give you a sense of scale, typical COVID SARS-CoV-2 virus is about 70 to 90 nanometers. That's 10 to the minus 9 meters. So it's really, really small. And these viruses are being carried out from our mouths and noses through droplets that come out when we are speaking, breathing, talking, sneezing, coughing, etc. And here's a little cartoon showing kind of how the virus might be kind of carried through these little droplets. And these droplets are very small. They range all the way, they can be large all the way to a few millimeters when you're sneezing, all the way to really, really small droplets that are less than a micron, that is 10 to the minus 6. So 1/1,000,000th of a meter in size. So that's the typical range. And from everything that we understand about respiratory infections, we kind of think of them as being infections being transmitted by 3 different routes, and they're connected with different sizes of droplets. So as you can imagine, and again in my talk, I'll be always signifying the infected person as this red individual. And this red individual is speaking or talking or sneezing. The person is creating these droplets. So the really large droplets are going to fall on the ground, they're going to fall on surfaces, or they might directly hit another person in front of them. And that transmission that happens through this direct kind of impact to another person who's close by, or maybe a surface, and somebody then touches the surface, all of this happens through what is called the large droplet route or the contact route. So this usually happens when the droplets are large enough, about 10 microns or larger, maybe even 20 or 30 microns. And then there is the airborne route, which is the cloud of droplets that are actually too small for us to see. So these are droplets that are smaller than 1/1,000,000th of a meter in size, typically. And these droplets basically suspend in the air, just like dust particles or pollen that causes allergies. These respiratory droplets are really, really small. They can suspend in the air for a very long time. And in principle, a person who happens to be kind of somewhere close to this infected person can inhale these droplets. So this last route is called what is called the airborne route. So it's very interesting and somewhat kind of disconcerting for us scientists that, through this course of this pandemic, we have actually gone through a tremendous kind of, not only evolution of our understanding, but really shows how poor our understanding was. So back in January to August of 2020, so that was the early kind of 6 months, 8 months of the pandemic, the whole focus was on large droplets, and CDC and World Health Organization, everybody was focused on large droplets. That's why they're talking about cleaning, washing, all of those other things that's connected with large droplets. And initially the understanding from all these agencies was that airborne route, the small droplet route, is not important. Then slowly this understanding started to change as more and more scientists kind of objected to this understanding of COVID transmission, and CDC and WHO started to acknowledge that maybe airborne transmission might be important, and that's why face masks are very important, et cetera, et cetera. If you remember in the beginning, in the start of the pandemic, many of these agencies were saying that face masks are actually not useful. So that started to change a little bit into the pandemic. And then more recently, this year, kind of 6 months ago, 4 months ago, CDC and WHO kind of almost reversed their stance now, and they now accept the fact that airborne transmission is the key. And in fact, the large droplets might not be very important. So it really signifies, so really what we are focused on is this cloud of droplets that's coming out, that's suspended cloud that other people might be able to inhale. And kind of in some sense, of course, among other things, this also shows the inability to really communicate the science behind COVID-19 effectively to the people in the policymaking apparatus as well as the public. So, and that's kind of a little bit of my focus of my talk, is really going to focus on how to frame science so that it becomes easily digestible by people from outside science. So, and what's my background and what's my expertise that allows me to talk about this? Well, so my background is in fluid mechanics. I was trained as an aerospace engineer, but I've for the last 10 or 15 years, I've worked quite a bit in physiological fluid dynamics, working in cardiovascular flows, respiration, things like that. So it turns out that COVID-19 transmission is also primarily a fluid dynamics problem. From a physics point of view, everything from the generation of these droplets to expulsion of the droplets from the mouth and nose, to the dispersion and transport of these droplets, and also the inhalation of the droplets by some uninfected person, everything is kind of modulated by fluid dynamics. And so given that, myself and a couple of my colleagues, we wrote a review article back in May 2020. It seems like ages ago now. We wrote a review article, almost like a call to arms to fellow fluid mechanicians, to kind of start to really get deep into the science of COVID-19 transmission. Interestingly, what happened as the result of that was that I started getting fielding inquiries from the media, from physicians, from dentists, from city officials, and what have you. And they were all wanting to ask me, what should we do? How should we protect our patients? How should we protect the citizens in our community, et cetera, et cetera. And what, the kind of the language that was available to me at that time to really explain some of the science and math was kind of encapsulated in these kinds of equations. So these are classical equations that are used in the field of epidemiology to describe how the probability of an infection, so P sub I is the probability of infection, how that probability actually depends on a lot of different parameters. And I figured out very quickly that these equations are very, very difficult to communicate to somebody who's from outside the discipline. So that was kind of the starting point of my thinking as I started to think about, how can we come up with a way in which we can frame this so that it's easy to understand. It is still very, very, very much rooted in science, but something that can be communicated across a variety of disciplines and even to non-specialists. So this is the whole, my talk kind of focuses on this. And funnily, I got inspiration for my work from this equation called the Drake equation. And for those of you who are ET aficionados, this is a very interesting equation that actually is a simple equation that tries to predict how many civilizations could exist in our galaxy that are capable of communicating with us. So how many advanced civilizations in the Milky Way galaxy? This seems like something that would be impossible to predict. And it is actually turns out to be very difficult and quite frankly impossible to predict. But nevertheless, this very simple equation that Dr. Frank Drake came up with, which is a multiplication of 7 different parameters, gives you the total number of civilizations. It's a very nice framework to really have a conversation about this topic and even try to understand what we know and what we do not know about something like this. So this was really the starting point. I started to think along these lines to see if I could frame something as simple and intuitive as this kind of a Drake equation. And I started off with this very basic idea. And by the way, this all evolved into what we ended up calling the contagion airborne transmission the cat inequality. And the basic idea behind this is that you have a host and you have a susceptible person. And basically, the susceptible person is going to be infected if the number of inhaled viruses, the number of viruses inhaled by the susceptible person is greater than the minimum number required to cause an infection. So that's the basic premise. And this is a very well-founded premise. This is underlying kind of all respiratory kind of aerosol transmission, is that if a person inhales more viruses than a certain minimum number, then that person can get infected. And on the left-hand side, the N inhaled is the number of virons inhaled by the susceptible. And on the right-hand side, there's a technical term for this called the aerosol infectious dose. So this is the minimum number of inhaled viruses required to initiate a COVID-19 infection in a susceptible. All right, so it seems simple enough, but actually it turns out, of course, that the devil lies in the details. And the question is, what determines this N on the left-hand side, the N inhaled on the left-hand side, and what determines this NC19, the number of the aerosol infectious dose? And of course, these two variables should include something about the host, something about the environment, and variables associated with the susceptible. So that becomes the issue now, is that can we kind of open up this onion and really try to understand what are the hidden variables inside this? And so bear with me as I kind of take you to the next slide and kind of show you a more complicated version of this. But you will notice that it is essentially the same inequality. On the right-hand side is the NC19, but now the left-hand side is opened up to really show you that, in fact, as we very well kind of intuitively understand, infection transmission is a complex process involving lots of variables. But let me see if I can kind of explain this. So again, there are three parentheses. There's the first parenthesis that has to do with the infected host. The middle parentheses actually involve the environment, environmental factors. And then the last four variables actually are connected with the susceptible. So the first variable is the number of droplets, the rate at which droplets are coming out of the mouth and nose of an infected person. And I'll talk about this briefly. The second one is how many of these droplets contain viruses, or what's the viral load of these droplets, right? So not every droplet is going to have a virus. So what's the average number of virons contained in these droplets? Then the face mask comes into play. If the person is wearing a face mask, then some of these droplets are going to be blocked by the face mask. So all of these numbers, these F numbers, are all fractional numbers. So they're less than 1. The other numbers can be greater than 1. So we have this face mask variable. And then we also have this variable FAH, which is that your droplets coming out, some are large, some are small. The large droplets are going to drop out. They're going to fall on the ground, so they don't matter. It's only the small droplets that are going to move and they're going to aerosolize. So that's the fraction of droplets that aerosolize. Then the environment actually plays a very important role in transmission. So how many of these viruses, these droplets actually transport through the air and reach the infected person? So that's a very important factor. You can imagine that if you're very close to a person, you might actually be exposed to more. If you're very far away, then these droplets might not travel that far. It turns out that beyond things like wind currents and air conditioning and things like that, even things like sunlight have a big impact. So that's the other parameter, is that these viruses do not like the sun. So actually, the UV rays contained in sunlight actually deactivate or kill the virus. So that is another factor that comes in as a fractional kind of reduction in the number of live viruses. And then the parameters associated with the susceptible, one is like, what is the concentration? How many of these viruses really arrive within the vicinity of the susceptible person? Is the susceptible person wearing a mask? If the person is wearing a mask, then a big chunk of these are going to be stopped by the mask. And then the time that the person spends exposed to this kind of virus-bearing respiratory cloud, that of course has to be a factor. And you can imagine if you spend twice the amount of time, your infection risk should go up by a factor of 2. And then finally on the right-hand side is also this NC19, which is the minimum number of SARS-CoV viruses. And that obviously has to depend on the health condition of the susceptible. So that is also a variable that is connected with the susceptible. So these are all these different variables. And again, to kind of put them in, what I'm going to really focus on the variables that we do not understand. And those are the variables that are these red variables. So these three red variables, the rate of droplet expulsion from the nose and mouth of the susceptible, the viral load, the average number of viruses that are expelled by an infected person in their droplets. And then finally, this minimum infectious dose. It turns out those three are the biggest unknowns in our ability to really pin down the transmission risk and the infection risk. The other variables are either fairly well understood, or they can be actually measured in some way or the other. We can actually obtain fairly good estimates of that. So for the rest of the talk, actually, for the next few slides, I'm going to focus on these three variables that are kind of unknown, because I think that's where it's kind of interesting to understand why some of this confusion exists and what we can do about it. So first of all, the rate of droplet expulsion from the nose and mouth. So a fundamental question is, where are these droplets coming from? When I'm speaking, unless I'm really speaking loud and I'm sneezing or coughing, I don't feel like I'm producing any droplets. But it turns out that's not the case. Every single breath that we take, every single syllable that we speak, every sneeze, every cough produces droplets. These droplets are, most of the time, they're too small for us to see. And they are being formed inside our lungs. They are being formed inside our respiratory tract and our vocal tract. And they're happening because our entire respiratory tract is lined by a layer of mucus. And that mucus kind of creates droplets as our lungs expand and contract, and as we breathe and do other things kind of connected with our respiration. So it seems like these droplets, we understand these droplets, we know where they're coming from. So what's the problem? Why are they still kind of an unknown? So it turns out that there is a huge variation in the number of droplets being produced depending on what we are doing and who we are. So for instance, sneezing is known to be the largest generator of droplets. So a typical sneeze can generate anywhere from 10,000 to 100,000, and some estimates even say 1 million. And this on the left-hand side is a picture taken with kind of background lighting showing a person who's sneezing. And you can clearly see that there's lots and lots of droplets coming out. Similarly, coughing also produces a lot of droplets, less than sneezing, but still thousands and tens of thousands of droplets. But the interesting thing about SARS-CoV-2, and one reason why SARS-CoV-2 became a pandemic that took over the world, is that this infection actually transmits even before a person starts to cough and sneeze. Even before a person shows symptoms, there is a huge viral load that starts to be shed by the individual. And that's the reason why one of the reasons why this virus has been so effective in taking over the entire world. And the point here is that it is for SARS-CoV-2, it is actually the droplets that are being generated during breathing and talking before the person gets infected, or maybe even a person who never shows symptoms, never coughs or sneezes. That infected person is still producing these droplets, and during the course of a day, even though you're producing only about 100 to 1,000 droplets or 10,000 droplets per hour of breathing or talking, but during the course of a day, you can actually produce hundreds of thousands of droplets, if not millions of droplets. So that's kind of where kind of the secret weapon that SARS-CoV-2 kind of wielded against us is actually right here. And you can see that measurements are not that easy. You can see a whole lot of variation in the number of droplets. In fact, you can see that every one of my estimate, which is obtained from various papers, is off by an order of magnitude, at least by a factor of 10. So this is just a difficult thing to measure, and it varies quite a bit. It varies even for a given person. That person might produce different number of droplets on a given day. The person might produce different droplets depending on what they have eaten or drank. So it really depends on a lot of different variables. So that's a huge unknown that comes into play. The second kind of the unknown that is particularly troublesome for us is the viral load. How many viruses are contained in these droplets? Not every droplet is going to have a viron inside it. And there's been measurements done by various groups trying to pin down this number. And I just want you to focus on this measurement. So this is the number of virus copies per sample. So what they did was they collected people breathing for 30 minutes, they collected all the droplets that came out, and then they did a PCR test on it to see how many copies of virus could they find. And basically, you can notice here that, focus on this aerosol particles less than 5 microns without mask. And you can see that the measurements vary all the way from kind of 0 or very close to 0, all the way to about a million. So that's the range of variation that we see just for people breathing for 30 minutes. These are different, they had many different, so each of these dots corresponds to a different person. So they had about a dozen or so people kind of, and they collected this data. So you can see a huge amount of variability in this variable. So this is a very difficult one to pin down. So the range could go anywhere from kind of 0 all the way to many thousands and maybe tens of thousands and even millions. One thing that I want to point out is that, there's also this whole notion, right, that this is aerosol the most important mode of transmission, or is it still the large droplets? Should we still be bleaching every surface and cleaning every surface and putting all these chemicals and things like that? So there's very clear data, and all the epidemiologists, the scientific community has kind of reached this consensus quite consistently over the last 6 months, 8 months to 10 months. So here's some data that shows that, so this is the number of viruses it takes to infect entity. In this case, they do these experiments on ferrets and animals like ferrets and mice, because you can't do these experiments on humans because this is dangerous. And bottom line is that the smaller this number is in this column, the more effective the transmission. This is the number of viruses it takes to create an infection. And you can see that the aerosol dose is about 600, whereas most of the other ones are 400,000, 70,000, 20,000. So the other modes of transmission are the nasal swab. You actually take a virus infused fluid and you swab the nose of the animal, or the intragastric route, which is through the mouth, through feeding the animal. So bottom line is that aerosol route is at least 100 to 1,000 times, if not more effective way of transmitting a virus than any other route. So really, this is where the battle is kind of been fought and won or lost, is trying to minimize aerosol infections. But this number NC19, which is the last variable that is particularly kind of important, current consensus, this is also a difficult one to pin down, because you can't really do, like I said, you can't do experiments on humans. You have to do experiments on smaller mammals and try to extrapolate from there what the number for humans would be. But from what we understand about similar viruses like influenza, which is also kind of a similar, it's a coronavirus it's a virus of the same family, not exactly, but similar transmission routes. Combining all that information, it seems like the number of virons required minimum aerosol infectious dose is anywhere from 100 to 1,000, order of 100 to a few thousand. So that's kind of what we understand. But again, you see that there's easily an order of magnitude variability in our understanding. So those are the three unknowns. So the question now, so by the way, we're talking about vaccines and kind of where do vaccines fit in there? Well, vaccines, what the vaccines are trying to do is they're trying to increase the right-hand side of this inequality. They're trying to increase the number of viruses it takes to cause a symptomatic infection in a person. So this is what the viruses are doing. On the other hand, this is what the vaccine makers are trying to do. On the other hand, what the virus is trying to do is trying to get around our defenses. So all these different variants that have come out, what they are trying to do through process of course, through evolution, is that these new variants kind of figure out a way to reduce NC19. And there's some notion that something like the Delta variant also increases the viral load. So it might be affecting not just the right-hand side of this inequality, but also the left-hand side by increasing the number of viruses that are being shed through the respiratory droplet. So that's kind of the kind of almost, you can think of it as a war going on between the vaccines and the different variants of the virus that are popping up around the world. So given all of this kind of unknowns, it almost seems like a impossible task to really, is it really impossible to gain any knowledge, understanding about transmission risk, and particularly this inequality? Can this tell us anything useful? And it turns out that while absolute risk is going to be difficult to predict because there's so many uncertainties about actual values, relative risk is actually fairly easy and intuitive to predict from this kind of an inequality, and so also from other types of mathematical models. So let me give you a couple of examples. The first one is that this whole idea about 6 foot, 6 foot social distancing, stay at a distance of 6 feet. This has become kind of part of, this is going to be part of the, all of humanity that has lived through this epidemic will remember the 6 foot rule. It's kind of become part of our lexicon of our lives. It turns out that in fact this 6 foot rule derives from loosely from a paper written in 1930s that had to do with large droplets. Kind of 6 foot in a very colloquial manner is kind of the typical distance that a large droplet would travel before falling if a person sneezes or coughs. And that is kind of somewhat irrelevant to aerosol transmission. Aerosol transmission, remember, this is not large droplets. These are small droplets that are floating in the air, and they can float forever. Literally, they can float forever. They can travel very, very large distances. So the 6 foot rule is somewhat archaic and it's kind of been misunderstood. But we can actually try to understand clearly more the distance, the better things are, right? So we understand that intuitively, but the question is, can we actually put some real kind of numbers behind this? And this is the first thing that we tackled. And I won't get into the details, but this goes back to kind of my bread and butter, which is doing computer simulations of fluid flow and trying to understand how turbulence, how different types of flows interact and how flows, especially flows associated with the human body, kind of what is the mechanics of those flows. So we used some very sophisticated simulations on very large supercomputers. These are very, very computationally expensive simulations. And we analyzed the results from this. And by using this cat inequality, bottom line is that what we determined was that the protection factor with distance is linear. So what that means is that basically, if you double your distance to the infected person, everything else being equal, on average, you will double your protection factor or you will half your risk. So every factor, every time you double your distance, you double your protection from a person. So I think, again, this is kind of the kind of insight that you get from this. Cat inequality doesn't tell you that, hey, if you should stand at 10 feet. No, it cannot tell you that. And actually, any model that tells you that, I would say, is trying to overpredict because there's so many uncertainties here. But I think the relative idea that if you double your distance, then you double your protection factor or you cut your risk by half. Those are the kind of things that are more dependably predicted by this kind of a model. So that's something to take away with you, that if you double your distance, you double your protection factor. Face masks, of course, this has become the front line in our battle to kind of defeat COVID. The face mask is probably the most simplest, most elegant medical device ever created, I think, in my view. And we have run some numbers through our model of various types of masks. For people, of course, you can go all the way to very technical masks like surgical masks, N95. But most of the masks that people wear on a regular basis might be made of cotton, might be made of kind of homemade masks or cloth masks. And it turns out that even with cloth masks, homemade masks, you can get a protection factor ranging from all the way from 4 to 16. If only one out of the 2 people is wearing a mask, you get a protection factor of about 4. But if both people are wearing the mask, then it's very easy. It's a multiplication of the 2 protection factors. So you get a protection factor of 16. So that's tremendous, right? That's tremendous levels of protection. Factor of 16 protection is almost similar to getting a vaccine. That's the same kind of protection you get. You start to reach levels that are very, very similar to getting a vaccine. So a face mask can be as effective as kind of getting vaccine. But of course, you have to wear the face mask in such a way that you don't have large leakages, et cetera, et cetera. Face masks, of course, have other effects, and I'll kind of skip this. This is the kinds of simulations that we do. This is a computer simulation of 2 people, one wearing a mask and the other one not. And you can see that the mask is filtering out a lot of the air, but it's also reducing the distance that this jet travels. So that turns out to be a very important factor. One last thing I want, oh, by the way, and it's well understood now that the masks actually help. There's some comparisons, very nice comparisons, let's say between multiple countries, so Italy versus South Korea, and infection rates in the two countries. And at some point, South Korea mandated the wearing of face masks, and you can see infection rates kind of died down. But then Italy did not, and this is kind of the way the infection rates increased before eventually coming down. And similarly, you can see comparisons between Czechoslovakia and Austria, which are very, very, geographically very similar, very, proximal countries. And you can see that the effect of kind of mandating masks actually has a huge impact on infection rates, etc. One last thing, I guess, we can also use this inequality to look at the effect of physical exertion. So as you can imagine that based on this inequality, the rate at which you're breathing out and the rate at which somebody else is breathing in is going to factor into the infection risk, because the harder the infected person breathes, the more viruses they put out. And the harder the susceptible person breathes in, the more viruses they can breathe in. So it turns out to be pretty easy based on this to kind of figure out infection risk as a function of exercise level. And it turns out by exercise level, what I'm talking about is even just walking around in your office and in a school or something like that. Already, if you do that, you're already considered to be at light or moderate kind of exercise intensity. And there, the risk already goes up by a factor of 10 to 50. So even moderate levels of activity, when you're breathing harder, increase the risk. But in a gym, when everybody is really at, doing vigorous exercise, factors of risk can go up by a factor of 200 or more. So this was particularly relevant about 6 months ago when there was lots of reports coming out that as gyms were open, they were becoming hotspots of COVID transmission. There were cases in Canada, cases in Europe, etc. So this inequality clearly tells you that, in fact, a place like a gym can be a very, very, you have to be very careful. If you're not wearing masks and you don't have good ventilation, the risk inside a gym can actually be very, very high. So with that, I'm coming to the end of my talk. I just want to kind of close with a couple of ideas. So for one is that, as scientists, I've been a scientist all my life. Sometimes, we feel that complexity is important, and things that are complex are worth studying. And that certainly might be true, but I think coming up with models that are simple and interpretable and intuitive, I think that's as important. And in fact, I love this this quote from which is this colloquially is known as the Occam's razor, that other things being equal, simpler explanations are generally better than complex ones. So that's something that certainly we've implemented in the case of this of developing this CAT inequality. Hopefully, some of this will be useful to you as you all think about infection risks and kind of how to deal with this in your local community, within your family. I'm going to close by just acknowledging my colleagues who've been key to a lot of this work. My colleague Charles Menevo, who's also a professor in mechanical engineering, Jung-Hee Seo, professor in mechanical engineering, and Ben Wu, who was a postdoc with me when we did this work, but is now assistant professor at University of Mississippi. And with that, I'll end my talk, and I'll be very, very happy to take questions. All right, so I'm starting to see some questions on the chat box. Question from John Richter. So does this type of calculation figure into formulas tracking transmission on a global or national level? How do these formulas work? So yeah, so these types of formulas are certainly, this is, the formula that I presented, it can be considered to be one in a class of epidemiological models called dose response models. So certainly these are the types of models that are being used by epidemiologists, by policymakers, by scientists who are trying to determine infection at the at community level, at local communities, cities, state, countries, etc., etc. So absolutely, I think this is exactly kind of the kind of formulas. What it comes down to is really trying to figure out with more accuracy each and every one of these variables. So that's where the kind of the devil is in the details, and these models exist, but the uncertainty in a lot of these variables is the thing that most scientists and policymakers kind of grapple with. Question from Dave: how do you account in the formula for things you don't know that you don't know? Yes, excellent question. So yeah, that's kind of how I framed the question. And in some sense, I kind of glossed over the fact that. So, for instance, I'll give you a question of there is a, when I say this formula, for instance, and I say that you need a certain number of viruses inhaled to be able to start an infection in a person. The people who are tuned in deeply into this will know right away that there is an underlying assumption here, is that the rate at which you take in these viruses is kind of being ignored here, because let's say it takes 1,000 viruses to create an infection in a person, but clearly that 1,000 viruses is, it's one thing to inhale those 1,000 viruses in a minute versus a day versus a year. And presumably, if you inhale 1,000 viruses over the course of a year, kind of 3 viruses a day, maybe your immune system can actually deal with it. So there are a lot of unknowns here. Is that, just one example on the right-hand side, should there be some kind of a rate of inhalation of these viruses also? So I think those are exactly the some of the unknowns. Now, how do we take account of that? Well, the way we try to figure out unknowns in any kind of a mathematical model is you start off with a model and you see whether that model is able to fit any data. And if your model, despite all kinds of variations, cannot fit data, that means that there's something missing, and that something missing could be some kind of an unknown. How can we use this to build better? There's a question from Erin. How can we use this to build better pandemic response? So I think number of things. So first of all, these kinds of models. So for instance, I think if you go back and look at our response, it fell short in many different ways. So this whole notion that aerosol is not important, this was a big shortcoming of our response. And I think if we had models like this, perhaps it would have been easy to explain to non-specialists and non-scientists and politicians and policymakers who are not epidemiologists. It would have been easy to explain to them that this, for instance, this NC-19, the number of viruses taken required to cause an infection through inhalation is thousands, if not tens of thousands of times smaller than that due to touch. And so maybe we would not have focused on bleaching every surface and putting all these chemicals and all the environmental and other kind of costs of this over, what's called hygiene theater, which is kind of cleaning every surface in sight all the time. So it could have helped kind of direct the resources and attention of the society and policymakers in the right direction. So I think that's kind of the underlying kind of hope, is that simpler models like this can eventually help us guide the response a lot better. How else can we make, so Erin's another question, how else can we make this type of information approachable to a general audience? Yeah, that's a good question. So, I think one of the things that I have always done as a scientist, I realized that I need to take out the time and effort to communicate my ideas to the general audience. Most of the time, people like us, we publish in journals, we publish in, we go present at highly technical conferences. But over the last, couple of years, and I've done this even before, I proactively reach out to outside academia and try to make myself available to different news outlets and things like that. I think that's one of the ways in which we can really kind of communicate this to kind of more general audiences. Is people like us need to get out in front of general audiences and make ourselves available to these general audiences. Do you have a rule of thumb for social distancing if 10 feet is not correct? So I guess you mean 6 feet. So it's a 6 feet rule is the one that's, so no, I think that's the other thing I would say. From everything that I've learned, there is no single distance that is the correct distance, right? If you are wearing a mask, 6 foot might give you tremendous amount of protection. But if you're not wearing a mask and the other person is not wearing a mask, then maybe even 20 feet is not good enough. You could be standing next to an air conditioning vent that happens to be blowing air from an infected person towards you. In that case, the distance is going to be, the 10 foot might not be enough. So I think the bottom line here is that those are exactly the kind of very specific things that once we understand the uncertainties involved, we can become comfortable with the fact that there is a certain level of uncertainty in all this. But overall, the rule remains is that everything else being the same, more distance, double your distance, you'll half your risk. So I think that's something that I keep in mind. When I go running or walking outside, if I'm walking behind somebody, I keep that in mind that, hey, if I'm walking 10 feet, if I move 20 feet back, in general, I'll be twice as safe. Let's see, what improvements might you suggest for mask manufacture? So that's a great question. And this is something that we are working on. So we have a grant from the National Science Foundation. We are working on trying to improve masks. Of course, the biggest problem with typical masks is the leakage. So all the masks kind of leak near the nose. We all know that. People like us who wear glasses, we know glasses fog up, and they're fogging up because there's air leaking out from near the nose bridge. So I think coming up with ways in which the leakages can be reduced, I think that's the key. And there is a lot of work going on. There are lots of lots of new ideas coming out. But of course, anything that makes the mask more difficult to wear is going to reduce kind of compliance with mask wearing. So it's a mask design is as much a sociological, kind of a exercise as it is kind of a physics-based exercise. So I'll kind of leave it. I'll leave that question kind of with another question. So for COVID skeptics, have you found ways to convince them that math works? I really, that's one that I admit defeat. I even have COVID skeptics in my close family, and I have not been able to convince them, despite the fact that some consider me to be an expert on COVID, and people like you log in to listen to me. I still have not been able to convince some people in my own family that that the science does tell us a lot about this infection, and kind of using science to help us tackle this is the right way to go. Do you have any recommendations to scientists who want to learn how to communicate their work better? Like I said, I think people like me need to realize that this is part of our job. I think for the longest time we think that talking to the media and all that is for the other people. It's not for me. I do deep science. But I think if you're doing deep science, then it should be likely is science that has implications for humanity. And in that case, it's our job to be able to convince, to be able to communicate this. So I think that's what I would say is that, I think communicating our science to the outside general audience is part of our jobs, both as scientists and as kind of human beings who have useful information to give out. Yvonne Higgins, how will this research inform building codes and ventilation? So that's another interesting idea. So that's a very critical component of coming back from COVID, right? COVID is going to change the way many things. It's already changed many things about the way we are going to be kind of operating as humans even far into the future. And certainly one place where we expect to see huge impact is kind of the indoor environment, right? Right now, indoor environment is all about comfort. It's all about temperature and humidity. But it turns out that in many cases that and also of course energy, right? So on one hand, we are trying to have the optimal comfort level for a human being inside. On the other hand, we want to minimize our energy expenditure that's required. But I think going forward, I think infection risk, respiratory infections, all that will have to will become more of a part of kind of ventilation design. And certainly I've had a chance to speak to many groups that are interested in this. Even at Hopkins, there are, of course, the Hopkins, facilities people are interested in this. So I think that's a very broad conversation that is happening among civil engineering, epidemiologists, and a vast array of people from different disciplines. Have you looked at the effectiveness of air cleaners, purifiers in combating COVID? I have not. So I have looked at papers, and the conclusion is that they do not work. And the reason is that these particles are so small. So for air cleaners to work, so the basic idea behind an air cleaner is you have a droplet floating in the air, you spray something that creates more droplets, and you want these two droplets to kind of join together, and so that the cleaner droplet can join with the virus containing droplet, maybe make it fall on the ground or maybe kill the virus. Now, that's the basic essence of all these air cleaners. Purifiers I'll talk about in a second. So those will not work because the probability that these two droplets will meet is like 1 in a trillion. So no droplet is going to meet another droplet. That's kind of well understood. Clean purifiers, so of course things like filters, right? HEPA filters, things like that, they absolutely work. If you were to take a typical kind of air purifier that you can buy, people usually buy them for people who are suffering from allergies, kind of can buy them and put them in their room, and it kind of cleans the air. HEPA filter will clean out all the virus containing particles. So HEPA filters can filter out everything down to 0.3 microns. So that pretty much 99.99% of all the particles can be removed from the air. So certainly using these kinds of filters can be a very effective way of kind of cleaning the air and reducing the chances of infection. From your perspective, what can doctors learn from engineers, and what can engineers learn from doctors? A great question. So I think, again, and by the way, being at a place like Hopkins is the perfect place to be, because this is one place where doctors kind of understand engineers, and engineers understand doctors to a greater degree than pretty much probably any institution in the world. So in some sense, I'm a little bit spoiled because I work with doctors who are inherently appreciative of what people like me can bring to the table. But I think in general, again, I think what the doctors can learn is that there is a math behind. Ultimately, there are models. There is a math that you can put behind a lot of these things. So that's number one. The other thing is that on the flip side, no matter how much math you put in, there is a high level of uncertainty and variability whenever you're dealing with the human body, whenever you're dealing with biology, whenever you're dealing with the environment, whenever these factors come in, inherently you have a high degree of uncertainty and variability that comes in. And the point of this whole thing is that despite this uncertainty and variability, there are useful and significant things that you can extract from these mathematical models. I think that's kind of what I think a physician or a doctor or somebody in the medical profession can take away from this. I think what the engineers can learn from doctors, I work very closely with cardiologists and I work with gastroenterologists. I work with respiratory disease people. And the thing that actually the thing that I've learned personally in working with doctors is that in the end, they bring a laser-like focus on one question and one question only. How will this help my patients? So in the end, they don't really care about elegant mathematics. They don't care about the complexity. They don't care about how many colorful graphs you can put in. They keep coming back with one simple question: how will this affect my patients? And I think that kind of a laser-like focus is something that can be very useful in any field, especially in my field as an engineer and as a person working in science. John Hunt, your simulation visuals were very effective. Please share those when you do media presentation. Hope they get shown to the public. Thank you. Absolutely. So these, of course, a picture is worth 1,000 words, and a movie is worth 1,000 pictures. So these visuals and these movies are quite can be quite effective ways in communicating these kinds of ideas. So I think that's the end of the questions. So I'll again really appreciate the opportunity to present this to this audience. Great questions. It really made me think, and I hope that this presentation will make all of you think a little bit more about how we beat this monster. Thank you.